Good morning, early birds. It's really an honor to be invited here to talk to you about waterborne disease and its association with drinking water in the United States and lack thereof. I'm happy to say that we've had a lot of successes in the last 100 years or so, but we have a lot of work to do. So the title of my talk is Glass Half Empty or Half Full: Successes and Challenges in Drinking Water and Public Health. Technical difficulties?
It's coming.
It is? Oh, yeah. Okay. I'm free to go? Okay. I'm obliged to tell you that these are my thoughts and not my agency's. So I thought I'd start with a prologue of my personal risk assessment. What do I mean by that? I think everybody who works in a given area of public health, you have a lot of insider knowledge about what risks are out there, and everybody kind of develops their own little quirks about what they're comfortable with and what they're not. I know people in foodborne who won't eat chicken in restaurants. I know somebody from parasitic diseases who will not eat raspberries anymore because of a nasty cyclospora outbreak she worked on. So when I'm out and about in my daily life in Atlanta and people ask me where I work, I say I work at the CDC. And they might say, oh, do you work in the lab? As though there's one lab at CDC. No, I'm an epidemiologist, and if that doesn't elicit the kind of blank stare or, something about skin, they might ask me what I actually work on, and I say, oh, I work on drinking water in the United States. And they say, oh, what's wrong with it? Or they ask me this question, or some variation of it. Do you drink tap water? Because they want to know, if I'm comfortable with it, maybe it's okay. And my answer, of course, is yes. I do drink tap water. Providing safe, piped, treated drinking water in this country is one of the great public health achievements of the 20th century. And we've come so far, and most of the time our tap water is of really high quality, and I'm absolutely comfortable drinking it when I'm at home, when I'm in a restaurant around Atlanta, when I travel to other cities in the United States. I don't worry, I drink tap water. But I am an epidemiologist, so there's usually a footnote, and the answer is always really, it depends. I do drink tap water, but if I'm in a campground, or if I'm renting a cabin in the mountains and I'm unsure about the source of the drinking water that's coming through the tap, I'm probably going to opt for bottled water, or maybe boil the water before I drink it. And I drink the water, but I don't use it to rinse my contact lenses, and I really try not to get it into my nose. And when I'm traveling, no matter how nice the hotel is, I always kind of think about the water quality coming out of the shower. And I'm really leery of hot tubs and the pools. So yeah, the water is safe to drink, but we do have some challenges, and there are some interesting things happening with waterborne disease in the United States. So for the next hour, I'm going to kind of share some of those with you. So first I want to talk about the glass half full part, which is really how far we've come. I feel like any talk about waterborne disease epidemiology kind of has to work in John Snow somehow, so I thought I'd get that out of the way in the beginning. It was really only in about the 1850s when John Snow did the first epidemiologic investigation, determining that cholera could be transmitted through drinking water. And so it's helpful to remember that's really not so long ago. Diseases like cholera and typhoid were rampant in major European cities and in the United States. So fast forward a little bit to the early 1900s in this country. Typhoid fever was a big problem. Typhoid fever is a severe diarrheal illness caused by Salmonella typhi, and it can be transmitted through contaminated food and water. This is a cartoon from the Virginia Health Bulletin in 1911. The caption is, "Are there any leaks in your dam?" And it's a representation of this kind of lake of typhoid infection being held away from this community by all these interventions: pure food, fly prevention, clean garden truck, clean oysters, efficient health officers, careful physicians, proper sewerage, pure milk, pure water, disinfection, and general sanitation. and then kind of oozing out the sides are personal carelessness and household carelessness. So you can see that, really not so long ago, just 100 years ago, people were still really worried about typhoid fever in this country. But, actually, before I get into the but, we have a kind of a neat data set at CDC. It's a line list of waterborne disease outbreaks that were compiled by kind of a precursor agency to the EPA. I think it was the Bureau of Water Hygiene. And so they have this compilation of waterborne disease outbreaks that were documented from 1920 to about 1970. This graph shows the number of typhoid fever outbreaks in the United States by decade. You can see in the 1920s, there were over 40 of them documented. This number fell off, but there were still, well over 10, 15 every decade through the 60s. But things started changing in the early 1900s. In 1908, the first U.S. city in New Jersey instituted chlorination of its public water supply. And in the years and decades that follow, many, many cities across the United States started treating their drinking water. And this graph shows death rates for typhoid fever and how they plummeted after this. But, other serious waterborne diseases that used to be commonplace really just went away. And so it really was a tremendous success story. And you could look at a figure like this and think, well, we solved waterborne disease, now let's move on to the next challenge. I thought it would be fun to look at a few of those outbreaks, the historic ones, and so we could kind of see the kinds of issues that we used to be dealing with in waterborne disease. A big typhoid outbreak in 1923 happened when water and sewer pipes were laid in the same trench along railroad tracks, and then vibrations due to the passing of trains caused leakage from the sewer, and this pollution entered the water main at a time of no pressure. Wonderful. Inadequate chlorination of the Missouri River, which was the source water, back siphonage and temporary cross connection in 1950. Actually, this is an issue that we still deal with cross connections between our potable water supply and, some source of non-potable water. But fortunately, typhoid is no longer endemic, so that's not usually what we get. Things related to mine drainage, contamination of the watershed, inadequate control over filtration. Untreated stream water used as a domestic source. Believe it or not, there are places in this country where people still do this, like in Alaska, where there are no other really great options. And finally, one from seepage of sewage from a collection main that was used by a carrier, and it got into a water supply. Typhoid, of course, wasn't the only pathogen that caused waterborne disease outbreaks between the 20s and the 70s. We still occasionally see shigellosis outbreaks with drinking water. This particular one from 1951 was caused by cross-connection with a school supply, which became contaminated by seepage of sewage. I think most of us send our kids to school, with the well-placed assumption that that's not going to happen. Our kids are not going to be exposed to sewage at school. Polio outbreaks, of course, we don't see these anymore. This one was caused by back siphonage of water from toilets. Hepatitis outbreak caused by back siphonage from clothes washers. An amoebiasis outbreak. We hardly ever see drinking water amoebiasis outbreaks anywhere in the world. But this one was from a leaking main transiently under negative pressure. A dysentery outbreak from a cross connection. This one's kind of neat. Bayou water and public water mains were somehow connected by means of a private lawn sprinkling system. And in 1958, another school-related outbreak of diarrhea of unknown etiology, where sludge was pumped out of, I guess, the cesspool, and then they used the same pump to supply the drinking water for the school. So, again, drinking water in school health is not really an issue we worry about too much anymore. So in that whole period of time, really what we're trying to do is keep the fecal contamination out of the drinking water. And this is an illustration from the 1930s, illustrating all the ways that typhoid bacteria could get into a well, into the water supply. So you have on the left somebody looking not too well, walking into the privy, and the collection pit underneath is leaking out and going to get into the water supply. Over on the right you have some runoff, which I assume is probably from the farm animals perhaps leaking down and getting into the into the cracked well casing, and then you have people above doing their laundry, and who knows, what kind of contaminants are in their clothes, and that's right there by where it could kind of leak into the well supply. So we now have modern water treatment systems with the goal, a lot of the goal, is to keep fecal contamination out of the drinking water. This is, of course, a vast oversimplification of what our water treatment systems do now, but this is a lot of it. So you want to start with the cleanest water possible, and it's important to protect our source water, so we've had a lot of interventions aimed at improving sanitation and wastewater treatment to keep our source waters cleaner. We filter the water, we disinfect it with chlorine or sometimes chloramine or ozone. We try to store it safely to prevent recontamination after we've cleaned it up, and then we have to distribute it to homes through pipes while maintaining that water quality. So I'm just kind of walk you through the steps of what goes into typical water treatment now. The source water, either a lake, a river, or a well. Groundwater or water from a well from underground supplies actually over 90% of the public water systems in the United States, and many of these are on average smaller systems. Surface water, including lakes and rivers, is typically not going to be as clean as well water from underground, but the majority of people in the U.S. are supplied by a surface water source because these are the sources that supply our larger cities. Once the water is drawn into a treatment plant, it's typically flocculated, so something's added to precipitate the solids out, and then it's filtered, and then a disinfectant is added before it is piped out into the community. It's stored in towers or underground tanks or reservoirs, and then it travels through a complex distribution system of pipes that bring the water to the end users in homes and hotels, university classroom buildings, etc. Everything before it gets to this point is regulated by the Environmental Protection Agency, but once it crosses the meter and it's on your own property, it's no longer regulated. It's no longer federally regulated, and it's up to the building owner to be responsible for the water quality then. So most of the time, the system works well. We have multiple barriers in place to protect our water, and most of the time, we don't wind up with a waterborne disease outbreak, but things do go wrong at every step in the way, and sometimes we do have a breach and we end up with a waterborne disease outbreak. So back in 1994, there was a really, really large outbreak of cryptosporidiosis in Milwaukee, our neighbor to the west. This affected about 400,000 people were estimated to be ill. This was the largest drinking water outbreak ever in the United States. Cryptosporidiosis is a diarrheal illness caused by the parasite Cryptosporidium, crypto for short. Crypto is a highly chlorine-tolerant pathogen. It can survive in an adequately treated swimming pool for 10 days. So the amount of chlorine that would be typically in drinking water, not going to do anything to it. And it's also a real concern for people who have immune-compromising conditions because it can just, basically your body can't fight it off. So this particular outbreak, over 400,000 cases estimated, 104 deaths, and the contamination was linked to one municipal drinking water plant. I know this newspaper picture is a little hard to see, but it says, it's from a pharmacy, it says, "We have Imodium AD, open Easter." And so it was traced to one particular drinking water plant where about over half the people receiving water from that plant became ill. This is a diagram of, kind of a schematic diagram of the setup here. We have intake 1 and intake 2 for the two separate water treatment plants. Sewage treatment plant is here, and the plume of sewage was kind of going out into the lake, and the intake for water plant 2 was right in that sewage plume. The attack rates in the various parts of the city are illustrated here, 53% down here, and 33 and 23% up here. Well, what happened to cause this outbreak? There were actually a number of things. I mentioned the sewage plume, but there were heavy rains around this time that increased the turbidity or cloudiness, churned up the source water. The intake was poorly located, There were some non-functioning monitors in the plant, so they had difficulty adjusting their coagulant, and they didn't have great turbidity monitoring. And they were recycling the filter backwash, which concentrated the Cryptosporidium oocysts and just made it that much more concentrated in the finished water. But it's important to note that although we did have water regulations, the system was in compliance with all the regulatory agency standards that were in place at the time. So it was recognized that something had to change because we just couldn't have this kind of disease outbreak in our drinking water systems. So the EPA, the Regulatory Agency for Drinking Water, has instituted a number of rules over the years that are aimed at reducing microbial risk and reducing risk from disinfection byproducts. I'm going to just walk quickly through a few of these. The Surface Water Treatment Rule in 1989 was issued to prevent waterborne diseases caused by viruses, Legionella, and Giardia, and it requires that drinking water systems with surface sources filter and disinfect their water. Notice that crypto is not mentioned here. Then the Interim Enhanced Surface Water Treatment Rule improves the control of microbial contaminants, particularly Cryptosporidium, in systems using surface water or groundwater under the direct influence of surface water. In 2002, they implemented the Long-Term 1 Enhanced Surface Water Treatment Rule, or LT1, which was aimed at strengthening control of microbial contaminants, especially crypto, in systems with serving under 10,000 people. So this is kind of the small systems counterpart to IESWT. And then in 2005, they instituted the Long-Term 2 Enhanced Surface Water Treatment Rule, LT2. And this is the rule that's kind of been gradually implemented over a series of years, depending on the size of the system. So the largest systems had to comply first, and then medium, and then smaller and smaller. So this one really cracked down on Cryptosporidium risk. It was aimed to reduce illness linked to crypto. Prior to LT2, a lot of systems with a surface water source were able to get these, meet certain filtration avoidance criteria and not have to filter their water. So, surface water is just, it's out there. It's inherently susceptible to contamination from the environment. And if you don't filter it, if you only disinfect, then there's always going to be a risk that a chlorine-tolerant organism could get into your finished water supply. Finally, all the other rules have been about surface water, but there's been a recognition that groundwater is not as pristine as people like to think, and we need some rules to govern the groundwater systems. So the groundwater rule has been implemented. Well, how do we know if all these rules make a difference? One thing that we look at is surveillance data. And the surveillance system that we use most often is the Waterborne Disease and Outbreak Surveillance System, or WebDOS. This is the only national data source that includes information on both illness and exposure. So we have lots of case reporting national surveillance systems, like giardiasis is reportable in most states, Cryptosporidium is reportable in all states. So we have national data on those, but those surveillance systems don't tell us anything about what led to people getting sick. What were the exposures? So this surveillance system captures information at the level of the outbreak. So you have information on both, like everything about the investigation, the environmental investigation, laboratory investigation, and the epi investigation, and what was determined to be the cause of the outbreak. It is a passive system, so we rely on states and other partners to investigate and voluntarily report outbreaks. So it's not 100% complete, but it's very useful. This is a map from a review of data from the system from 1971 to 2010. It's kind of a funky color scheme, but it shows the number of outbreaks in each state. You can see Michigan up here in blue. It's kind of in the middle of the number of outbreaks reported. We never look at maps like this and make quantitative comparisons and say, say Missouri has more waterborne disease outbreaks than Kentucky, because we know that different states have just placed different priority on investigating and reporting waterborne disease. So a state that reports a lot, we don't necessarily assume that they have a bigger waterborne disease problem. It might just be that they are really on top of it, maybe have some extra resources, some extra funding to investigate waterborne disease outbreaks. So what happened to cryptosporidium after all these drinking water regulations were implemented? Gosh, overall crypto has really gone up. Why is that? Well, if you look at this more closely, this is a stacked bar chart. So the top bit in the dark red color is the drinking water associated outbreaks. The yellow ones are outbreaks in untreated recreational water like lakes and rivers. And then the bright green color is outbreaks in treated recreational water. So once cryptosporidium emerged as a cause of waterborne disease outbreaks. We saw some big outbreaks in drinking water, but then it really became a treated recreational water venue issue, and we see a lot of swimming pool related outbreaks, and that's what's really driving crypto now. But it's been a pretty much a success story with respect to drinking water, because after Milwaukee and one other outbreak, we didn't see a drinking water related crypto outbreak for 20 years until 2013. Looking at another pathogen, this is outbreaks of giardiasis associated with drinking water. And the different colors on the bars indicate the deficiencies associated with these outbreaks. The light blue color is treatment deficiencies. And you can see that the number, on the left side of the histogram, we see a lot of that color. We saw a lot of giardiasis outbreaks associated with treatment deficiencies, but we started really cracking down on surface water treatment, and now we don't see very many of those anymore. What remains is really outbreaks associated with untreated groundwater, the light gray color, a little bit of point of use, and some distribution system deficiencies. So you've seen we've come a long way, and these are all the things that we've done to make our water better. But it's not perfect, and there are some interesting new things to worry about. So now I'm going to talk about the glass half empty part. Okay, so we've gotten pretty good at keeping the fecal contamination out of our drinking water, but these are estimates that were published in 2006 using various methods, some quantitative microbial risk assessments and other things, to estimate the number of cases of acute gastrointestinal illness that occur as a result of problems in public drinking water systems every year in the United States. The green estimate of between 4 and 11 million cases. The red estimate of 16.4 is the point estimate, so millions of cases. I think the situation is probably not, these numbers are probably a little high, in part because we've done things since the time that these data were, the assumptions in these estimates were created, or the data was collected to make things a little better. But, it hasn't gone away. We just don't see the same kinds of outbreaks that we used to see. But, where we're dealing now with kind of the other side, like we built these systems, but we haven't really taken care of them. The water pipes are underground. They're easy to forget. Infrastructure's been in the news. You've probably heard news stories, heard the president talking about, we need to invest in infrastructure, but he's talking about bridges and roads, and I've never heard him mention drinking water infrastructure. But in many parts of the country, this infrastructure is over 100 years old, and it was really not designed to last that long, so it's at the end of its useful life. The American Society of Civil Engineers gives our water infrastructure a grade of D. We have about 240,000 water main breaks in the United States every year, which make an opportunity for, the water pressure goes down, and there's a potential for contaminants to intrude into the drinking water system. And we really have an unknown burden of disease from these events. So a big question that's out there is, do water main breaks and repair events pose a public health risk? A study was conducted in Norway several years ago that found that yes, residents of areas that were subject to a low pressure event had 58% higher risk for acute gastrointestinal illness as residents in areas that were not affected by the low pressure event. But we had no comparable systematic data collected in the United States. But we're working on it. CDC is doing this study, for short, the CDC Water and Health Study. The objective is to assess whether individuals exposed to low pressure events are at an increased risk for acute gastrointestinal, acute respiratory illness. We completed a pilot study at one utility last year. There are a lot of moving parts with this. The devil's in the details of figuring out who's exposed and who's not, and getting a decent survey response rate. We are currently in the process of recruiting additional utilities to make this a nationwide study, and always happy to hear from additional utilities that might be interested. So If you anyone here happens to have a good relationship with a water utility that you think might be a good candidate to participate in this study, please let me know. Love to talk to them. So far I've mostly talked about the public drinking water systems, but a lot of people do not have access to a municipal water source. And private wells are the primary source of drinking water in many counties in the United States. The darkest blue color here indicates counties where over 50% of the population relies on a private well. You can see Michigan here has a lot of that color in it. So people who have a private well are kind of on their own. There are no federal regulations governing the water quality, and a lot of people either don't know that they're responsible for it, don't know what to do, or they're just not motivated to do what they need to do. It's about 1/6 of U.S. households rely on a well, but there are definitely some health risks. The American Academy of Pediatrics has put out guidelines for increased well testing if infants, children, and pregnant women reside in a household that is served by a private well, because children are especially susceptible to diseases from potentially fecal contamination, also naturally occurring chemicals like arsenic, which is a problem in certain regions of Michigan, and agricultural and industrial contaminants like nitrates, volatile organic compounds, etc. And I don't know how many of you with kids have ever had your physician, your pediatrician ask what kind of water you have at home. I know they've never asked me. So they make these guidelines, but there's a lot of things that pediatricians have to cover in a well child visit, and I don't think water often makes the list. And then there's places in the country where people just don't have access to groundwater, and they don't have a municipal water source, so they get their water from a rainwater collection system or a cistern, or maybe a spring that looks like it comes from underground, but it's really under direct influence of surface water. So there's no federal regulations, and some states have some requirements, but typically we think most people with private wells do not do everything that they could to make sure that their water's safe. And then beyond the private wells, there's the public wells. We have a lot of untreated public groundwater systems. The regulations from EPA, which states have interpreted these in different ways, but a lot of systems that serve under 10,000 people that get their water from an underground well are not required to chlorinate. So that water, it might be fairly clean when it comes out of the ground, although it probably is not as free of viruses as people like to think. But it's also susceptible to contamination as it travels through the distribution system when you have cross connections or low pressure vents or anything like that. Contaminants can intrude into the system, and if there's no chlorine there to kill pathogens, then people are vulnerable, and a lot of people can be affected by an outbreak. We still see a lot of really large outbreaks of things like Campylobacter, occasionally giardiasis, salmonellosis in untreated groundwater, public water systems. A lot of work has come out of the Marshfield Clinic group in Wisconsin looking at the health risks from these untreated water systems. This particular paper was from AJPH, and it was about diarrhea in children. Okay, now moving on to something that's not related to fecal contamination is biofilms and premise plumbing. This picture on the right is the inside of a pipe that's been in use for some time. They don't stay looking like they look in the store. Once they've been in use for a while, things accumulate on the inside of the pipe. This is actually kind of normal. There are normal, there's a microbial community that lives in the water. It's not sterile. Things attach to the side, and this creates a complex ecology on the side of pipes, and then it can occur throughout water systems. But, I mentioned earlier, the water's not EPA regulated after the meter once it's in a building, and within the pipes in a building, conditions are perfect, can be perfect for biofilms to really proliferate. You have water that's more stagnant. The disinfectant residual is lower because the chlorine doesn't, you put it in, it doesn't last forever, it dissipates, so once it gets into the building, it might be really low or undetectable. You have situations where you have warmer water temperatures, like if you have a water heater. All these factors contribute to biofilm development, and it creates an optimal environment for some really lovely biofilm-associated pathogens to amplify and reach susceptible hosts, because it's right where we're using the water. This is a kind of a cartoon of how these biofilms might grow and accumulate and proliferate. and the organisms that might be there. These include free-living amoeba. There are lots of species of free-living amoeba that live in water systems. Some of them are pathogenic, many are not. There are other microbes called, here they're called amoeba-resisting microorganisms. So normally the amoeba survive by feeding off of bacteria, and they engulf it and digest it, but organisms like Legionella and non-tuberculous mycobacteria are amoeba-resisting. So they get engulfed by the amoeba, and they live there happily. The amoeba encysts itself, so it's protected from disinfectants, and then it grows and multiplies in the amoeba, and eventually the amoeba kind of bursts, and all these bacteria, Legionella, are released into the water. So Legionella is kind of the poster child for biofilm-associated or opportunistic premise plumbing pathogens. It's the causative agent of Legionnaire's disease, which is a severe pneumonia. It also causes Pontiac fever, which is a self-limited, more flu-like illness. And it grows in warm water environments in biofilm. And you contract it following inhalation of aerosolized contaminated water. There are some personal risk factors, being slightly older, being a current or former smoker, having chronic lung disease like COPD, which is really not good for any aspect of your health, and then having an immune-compromising condition. This is a histogram of all the waterborne disease outbreaks associated with drinking water from 1971 to 2010. So you can see that over time the number of outbreaks has decreased. But I want you to focus on that light gray hash mark at the beginning, because it looks like in recent years that Legionella outbreaks have been increasing. And here's another way of looking at that. This is data from 2009-2010 from WebDOS. The pie chart on the left shows the number of outbreaks, and the light green color shows that 57.6% of all the outbreaks were Legionnaire's disease outbreaks. The pie chart on the right is cases of illness, and here you have to keep in mind that Legionnaire's disease outbreaks tend to be pretty small, in fact maybe 2 to 6 people on average, so whereas our traditional bacterial disease outbreaks like Campylobacter can affect hundreds of people. So they're still the minority in terms of outbreak-associated illnesses, but the majority in terms of outbreaks. I thought I'd share this one. This was an outbreak of Legionnaire's disease that occurred in Michigan. It's not related to a potable water supply. It was actually linked to a cooling tower. But this was a really large outbreak, 64 cases of Legionnaire's disease and Pontiac fever. They did a cohort study to, like right here, this red cross. And up here is the location of the cooling tower. And they found that people who worked in Building A, right next to the cooling tower, had much higher incidence of illness than residents, or not residents, but workers in Building B, for example. So there's kind of just an endless variety of setups for Legionnaire's disease outbreaks. It can be in your potable water system. You can get it from a shower. We see outbreaks in long-term care facilities and nursing homes where you have a large number of susceptible people. Also hospitals, nosocomial outbreaks. We see them associated with decorative fountains, misters in grocery stores, hot tubs. I mentioned I'm always leery of hot tubs in hotels. There's why. Other reasons too. They're not all that well maintained sometimes. My dog, we went to Six Flags, an amusement park in Georgia last summer. It's really hot. They have like these little things, these towers you can go and push a button and it puts out this plume of cooling mist, and I just kind of okay, she's really young, she's got a good immune system, she doesn't have lung disease, she's not a smoker, it's probably okay. Okay, another pathogen that we're seeing increasing risk of is non-tuberculous mycobacteria, or NTM. This is found in soil and water. Sometimes people talk about MAC, or Mycobacterium avium complex. Causes a severe lung disease. It's not tuberculosis, it's not transmitted the same way, but it can be really severe and life-threatening. It also can cause a cutaneous or disseminated disease. And it is also similar to Legionnaire's disease, can be attracted from inhalation of aerosolized contaminated water, or it can come from the soil, or you can get it from a wound infection. It can be difficult to diagnose because it kind of has a slow progression, and for that reason it's kind of more chronic looking and it's difficult to detect outbreaks. But similar risk factors to Legionnaire's disease. Pseudomonas is on our radar as a biofilm-associated pathogen. This is ubiquitous in the environment. Really, you can find it anywhere, but it likes to live in water. It loves to live in biofilms and premise plumbing systems. One of the pathogenic species is P. aeruginosa. Infections can range from mild, almost a nuisance, to severe. Causes a lot of otitis externa, or swimmer's ear, and folliculitis, or hot tub rash, another reason to kind of skip the hot tub. And also can cause really severe and scary infections that are life-threatening, including pneumonia, sepsis, and surgical site infections. We also see a lot of healthcare-associated infections of Pseudomonas that might be linked to the water in some way, because perhaps somebody rinsed a medical instrument in tap water, or also just general hygiene issues. It's easily cultured, so we're not really sure that all the Pseudomonas infections that we pick up on in healthcare databases are clinically significant. Okay, moving on to some free-living amoeba. Acanthamoeba is a free-living amoeba that is pretty common in the environment and pretty common in tap water. It's the cause of Acanthamoeba keratitis, or AK. This picture is a cornea that's been kind of partially digested. It can cause blindness. It primarily affects healthy contact lens users, and risk factors include poor hygiene, using contact with non-sterile water while wearing lenses, showering lenses, swimming in lenses, rinsing, storing your lenses in tap water. So you don't want to do that. You want to use a more sterile water source when you're using a medical device like a contact lens. It can also cause granulomatous amoebic encephalitis, GAE, which is an opportunistic brain infection that can be fatal. But yeah, it's really rare. Probably won't get it. Naegleria fowleri is also just a really scary bug. Also kind of known in the media as the brain-eating amoeba, because that's what it does, really, literally. But normally it just kind of lives in the sediment at the bottom of a nice warm lake or pond, and it's perfectly happy to eat bacteria. But if it happens to get in your nose and travel all the way up into your brain, it causes primary amoebic meningoencephalitis, or PAM, which is an almost universally fatal brain infection. We've actually had a couple of survivors in the last couple of years, one of whom made a full neurologic recovery, but most of the time, by the time this is diagnosed, the person is dead in 5 days. We've fortunately had only 300 to 400 cases worldwide. Most infections are from swimming in lakes and rivers, water where maybe you're roughhousing and kind of playing really hard and the water goes way up in your nose. And until 2010, all infections had been in southern tier states. In 2011, in Louisiana, things started getting really interesting. We had 2 adults who died with PAM in different parts of the state. One was down by New Orleans and one was up by Shreveport. Neither one of them had a history of swimming, so where did they get this? Well, it turns out they were both regular users of neti pots for nasal irrigation, and they had both used their tap water in their neti pot. And they inoculated the amoeba right into their nose. In both cases, those residential plumbing systems were positive for Naegleria fowleri, but at the time, the investigators took a limited number of samples from the distribution system and did not find it in the potable water, or the distribution system for the city water. Fast forward to 2013, and a little 4-year-old boy was diagnosed with PAM on autopsy. They initially thought he had West Nile encephalitis, I think. But this was a little boy who didn't like to get his head underwater. He didn't have any freshwater contact. His only real recreational water exposure was that he had played all day on a slip and slide connected to a treated municipal water supply. So as part of this investigation, they shipped all the hoses and the slip and slide to CDC, and our lab people had fun trying to figure out how to get samples from those items. And they did isolate Naegleria in the residential plumbing system, also in the hot water heater and the hoses supplying the slip and slide. But this happened in the same parish as one of those 2011 neti pot associated cases. So they thought, this is starting to look like an outbreak. We have 2 cases, epidemiologically linked. So they did some more extensive testing of municipal water supply and did some ultrafiltration, so large volume water sample testing, which increases the sensitivity. And they did find that the distribution system was, had Naegleria growing in it. So this resulted in an emergency rule. They had to, the system had to go through a chlorine burn to try to get the biofilm out of the system, and the state actually decided that statewide all water systems had to increase their chlorine levels, because they also found it in the other parish water system where the other 2011 neti pot case had occurred. So it's looking like a wider spread problem than we had realized. But only in places where it's really warm and where the water system was really warm so far. So I don't think you have to worry about this in Michigan yet. U.S. Virgin Islands in 2012, a 47-year-old Muslim male died, and he was diagnosed with PAM. He also had no recreational water exposure, but he practiced ritual ablution, including nasal rinsing, which is part of a preparation for prayer in his faith. The investigation looked at a number of water sources that he might have had contact with, including his home water, which included untreated water from a well and untreated rainwater from a cistern, water at the mosque, and treated municipal water, which were both desalinated and chlorinated, and the mosque also had a filter. The investigation really pointed to his home as the point of exposure, because when you don't have any chlorine in the water, these amoeba could be growing there. So in response to this, and part of the investigation, the EIS officer and a health communicator did a lot of qualitative interviews with the community to understand people's understanding of, what makes water clean enough for this practice, and what are the practices. And we've heard about this type of exposure leading to PAM in other countries like Pakistan. So we felt like we needed to do something to make people aware of this risk. We don't want to change people's practice of their faith. We just want them to be aware that some water might be more appropriate than others. So we worked with some national Muslim groups to develop guidance for safer ritual nasal rinsing. Okay, now moving on from free-living amoeba, climate change is, it's going to affect everything as things get warmer. But in terms of waterborne disease, it can impact the range of waterborne pathogens, increase the number of extreme weather events, which can have a detrimental impact on our vulnerable drinking water infrastructure and also our wastewater infrastructure. And our water use patterns are going to change. We're going to use those cooling misters more often and swim more often. So it's going to lead to more opportunities for different waterborne disease risks. Back to amoeba for a moment. This is a map of cases, 132 cases of Naegleria fowleri infections by state of exposure in the United States from 1962, when we started kind of being aware of this, to 2012. I said until 2010, all cases had been in southern tier states, but it seems like it's moving northward. We've had in the last few years cases in Kansas, Missouri, and Indiana, and 2 cases in Minnesota, which is not the South. So all these have, all these northern cases have been associated with recreational water exposure. But when water heats up, when ambient waters are warm, there is a risk. There is potential. So we haven't had it in Michigan yet. Could happen. Another climate-related water issue is harmful algal blooms. Last year in August, there was an algal bloom in Lake Erie. I guess it happens every year, but this particular one was in an area where the water intake was for a large drinking water system. Microcystis, which is a type of blue-green algae, were growing in this bloom. This produces microcystin, which is a toxin that can cause numbness, nausea, dizziness, vomiting, and can lead to liver damage with higher levels of exposure. And in August 2nd, the city of Toledo was monitoring for this in their water, and they found microcystin in their finished water at exceeding 1 part per billion. It's not a very high level. U.S. didn't really have any guidance for what levels are acceptable in drinking water. EPA had not weighed in on this, so they were going by a WHO recommendation. So a do not drink, do not boil advisory was issued for Toledo and several counties, including I think 2 counties in Michigan. It only lasted a couple of days. The advisory was listed on August 4th. I'm not going to talk about this a lot, but they did a CASPER, a community assessment for public health emergency response, and the report has been issued. It's on the Ohio State Health Department website if you'd like to go look at it. In response to these issues of harmful algal blooms, which has historically been more of a recreational water issue, something people get exposed to through swimming, or maybe their pets swim into a pond and get sick or die. But there are, human illnesses. We've had historically a harmful algal bloom surveillance system. Right now, we have funding through the Great Lakes Restoration Initiative to do some activities at CDC. And these include moving, improving, and reprogramming the old HAB surveillance system onto a national platform. So this is a system that's kind of being done through GLRI funding for Great Lakes area needs, but it's going to be accessible nationwide. We've also been able to place applied epidemiology fellows in several Great Lakes states, including Michigan. Hello, Lily. And so progress towards this surveillance system include a state federal working group that did a lot of work in 2014. The One Health HAB reporting system is going to pilot this year. So starting, I think, this summer, people will be able to enter cases. We have fellows in Indiana, Minnesota, Ohio, Wisconsin, New York, Illinois, and Michigan, who are doing a lot of really great waterborne disease work and getting integrated with their local health department or their state health departments. So I think what all this is pointing to is that we have, our drinking water is not just the water that we drink. We rely on this water source for all kinds of things, and we need to be aware that our drinking water is safe to use, it's safe to drink, but it's not sterile, and it's not meant to be sterile, it's never been sterile, it's never going to be sterile. And illnesses can be transmitted in other ways than just ingestion. So it's not just about the water we drink, it's the water we shower in, the water we use for our personal care and hygiene, water that we play in. And it's not even just our potable water systems, because we interact with all kinds of water in all kinds of ways, through cooling towers, decorative fountains, recreational water. And this has really led to, I think, what we have to think of as a new paradigm of waterborne disease in the developed world, where it's not just about protecting ourselves from fecal contamination in our drinking water, but it's about all the ways that we interact with water, the unintended consequences of having a generally safe water supply, and maybe we trust it too much and use it for things where we shouldn't, having expanded water uses, post-industrialization effects like old chemical storage tanks that leak into the river and shut down the water supply in Charleston, deteriorating infrastructure, medical uses of water, where the quality is not always as good as it should be, urbanization and human-made habitats, which have created new niches for certain pathogens to exploit, and biofilm and premise plumbing issues. This is complex. It's a complex world of waterborne disease, and it's hard to communicate with policymakers, and we think that having some numbers to back this up will be helpful. So we have a goal to create the first comprehensive estimate of illnesses, hospitalizations, and deaths and cost from the full spectrum of waterborne diseases in the United States. Just a small little project. We're looking at all types of waterborne disease, and our goal is to include all types of water exposures, including not just drinking water, but recreational water and other environmental water exposures like cooling towers, decorative fountains, occupational exposures. And our work so far on this project really shows the impact of premise plumbing pathogens. So our approach to building this estimate is kind of doing it in a stepwise fashion. A colleague published a paper on the number and cost of hospitalizations for 10 pathogens that can be transmitted by water. We're working on a paper on mortality from 15 waterborne pathogens, another paper on emergency department visits and hospitalizations for other pathogens, some work on outpatient visits, which our data is more syndromic, and finally, somehow magically in the end, this is all going to come together in one big estimate of the total burden of waterborne disease in the community with attribution to water, because we know that a lot of the pathogens that can be transmitted by water can also be transmitted other ways in our food and in the environment. It's really challenging because you guys might be familiar with the CDC's foodborne estimate. They have laboratory-based surveillance for various GI pathogens. We have to think about more than just acute gastroenteritis, because waterborne disease can affect all kinds of systems: neurologic infections, eye and ear infections, respiratory infections, wound infections, skin infections, etc. So, there's no single surveillance system that's going to give us all the information we need. there's a almost mind-boggling number of pathogens with potential for waterborne transmission. But fortunately, we think that we can capture most of it by looking at a shorter list. So we've kind of subdivided these, since we don't have a really great handle on attribution yet. We've kind of subdivided these into the primarily waterborne group, which we think is at least half is transmitted by water, and the partially waterborne group, which we think is probably less than half. And the ones in yellow here are the kind of new paradigm premise plumbing pathogens or biofilm-associated pathogens. So work so far. Hospitalizations from the 10 primarily and partially waterborne diseases. On the primarily waterborne group, giardiasis, crypto, Legionnaire's disease, otitis externa, NTM, these are estimated to lead to over 40,000 hospitalizations per year at a cost of $0.9 billion a year. Legionnaire's disease alone is responsible for over 12,000 of those hospitalizations and about $4.4 billion. And NTM infections, even more, 15,000 plus hospitalizations a year, costing another $0.4 billion. So it's a lot of hospitalizations, and they are very costly to treat. A preliminary look at annual deaths from selected pathogens. This is largely relying on death certificate data, which is not optimal. We think these, as a result, these are probably conservative estimates, and they're also supplemented with some other data sources. These are ranked in order of number of annual deaths, and you can see at the top of the list we have Pseudomonas, non-tuberculous mycobacteria, and Legionella leading it. So out of the over 2,500 deaths, kind of documented deaths from potentially waterborne diseases, 2,200 of those are from premise plumbing pathogens. So kind of summing that up, our enteric pathogens, we see a lot of them, maybe millions of cases a year transmitted through water in this country, but very low mortality. Whereas our biofilm pathogens, maybe a smaller number of infections, but higher, greater consequences, more hospitalizations, more deaths. So what do we do about this? How do we prevent these illnesses? Our old paradigm was all about preventing exposure to feces, and we need strategies for preventing exposure to biofilm pathogens. We don't really know for sure how much is transmitted through drinking water versus other sources of water. We don't have great indicators of when these pathogens might be present, because our indicators are all about detecting fecal contamination. We're not really sure how to go about intervening when the premise plumbing systems are unregulated. It's really not really fair to rely on homeowners to say, oh yeah, you need to make sure you don't have Legionella growing in your shower. Which premises are most at risk? Is this really more about the large, complex building plumbing systems, like in hospitals and health, hotels, or is it also a big problem in people's residences where we're unlikely to detect outbreaks? And finally, who is most at risk? Do we want to intervene to protect everyone, or do we want to focus on the people with risk factors, the people who are older, the people who have lung diseases? So in this new paradigm, the health communication messages get really complex. We really don't want to undermine confidence in drinking water, because it's really one of our most important basic public health protections. There's so many good things about our drinking water, but there's always caveats and complicated things that we need to tell people, and we don't want to undermine confidence. So I'm going to give you some examples of what I mean. The simple message that we'd like to give is tap water is reliable. You can count on it. But we also want you to know that you need to be prepared for water emergencies and store at least 3 gallons of water per person per day, and don't forget your pets. Natural disasters, chemical spills, algae blooms, and water main breaks can occur. And you need to pay attention to local water advisories. If your local health department tells you you should boil your water, or don't drink the water, or don't shower in the water, you should pay attention to those things. But really, it's reliable. The water supplied by your public water utility is very good. That's true almost all the time. But once the water enters your house, hotel, or hospital, the quality can decline, and who knows what's really living in there. The EPA regulates public drinking water systems, and the standards are high. Yes, that's true. If you have a private well, though, you're solely responsible for ensuring your water is not contaminated with parasites, viruses, arsenic, nitrates, and VOCs. Tap water is safe to drink. That's true most places, most of the time, but tap water is not sterile and should not be used with medical devices. And this is a really difficult message to get across. In a community that has had Naegleria fowleri detected in their tap water, where people are panicking and they're turning off water fountains in the schools because they don't know, they don't know if it's a risk. To tell people, yes, the water is safe to drink, no worries, you can drink the amoeba, your stomach acid's going to kill it, it's not a problem, you can't get PAM from this, just don't get it in your nose because it could kill you. That's really difficult. So if there's anybody who's a really talented health communicator who'd like to help us with this issue, we'd love to talk to you. Also, if your immune system is compromised, you might want to consider drinking specially treated water because we can't absolutely guarantee that there's never going to be a Cryptosporidium oocyst in your finished water. So at the end of the day, is the glass half full or half empty? Well, yes. On the positive side, filtered chlorinated water is a really amazing invention, and I'm really happy that we have it. And we have seen declining outbreaks of gastrointestinal illness from our public water supplies. And the quality, because of the regulations that have come on board, the quality gets better and better, and new technologies improve our water all the time. But we have a lot of people relying on unregulated wells, and they might not have access to the best quality of water. We have deteriorating infrastructure, and nobody really wants to pay for fixing it. We have these complex situations with premise plumbing pathogens, and we have expanded water uses. So, it's really an interesting place to work in drinking water in the United States because the variety of issues that we encounter is really great. And it's not just about, one type of illness or one pathogen. It's really a diverse situation. So with that, I'd like to acknowledge the state and local health departments that work so hard to detect, investigate, and report waterborne disease outbreaks, because without those, we would not be able to have a very good handle on what's happening out there. And I'd like to thank all the people in my team that I work with at CDC whose work has been represented in various ways in this. Thank you.
We have a few moments for questions.
Yes? We don't really have anything in place to monitor that. We're very interested in that issue. And we've had, I think we had a pharmacist who was working with us for a while who really wanted to work on that, and it turned out that there was a turf issue with FDA. FDA is really thinking about that issue, so. Yes?
What recommendations would you make to a private well owner regarding testing and treating of the well? Maybe what frequency you would do that?
Our general recommendation is that you should have your well inspected and some basic water quality tests done annually, and then retest if you notice any change in your water quality in the taste or odor, or if something has happened in the area, like you've had flooding or some other issue. And we usually refer people to the state or local health department for specific recommendations about contaminants of particular concern in your area. Because not everybody needs to test for everything, but there are some areas where arsenic's a problem or nitrate's a problem, and your local health department would be the best source for that information. Yes?
Have there been efforts in terms of policy in regards to the old infrastructure and the concern over our uptake in infectious outcomes because of our culture?
I didn't catch the very first part of what you said.
The policy, have there been any efforts in terms of policy making or going back to the bill by the CDC to make a stand?
So I think a lot of people kind of in the water community, at least the more public health oriented people, are looking for eventually for there to be a distribution system rule. And what we're doing toward that is doing our distribution study, doing our low pressure event study to provide actual human health data to indicate whether this, how big of a public health issue this is. There's been other efforts going on, not on the policy side, but on the science side, trying to, improve response to low pressure events. But I think it's not really CDC's role to advocate for funding to fix infrastructure. We just put the science out there as best we can. Yes?
Some of these models that you're creating in terms of the overall
Yes.
And we have a population with increasing chronic disease burden, which leads to more immunosuppression. And are your models going to forecast out?
I'd say, we're trying to come up with some numbers that are going to be fairly crude, but there will be a lot of a lot of the small print. We'll address that. Our work in the paper that we're working on mortality looks at the age of the people who are affected, and we're kind of looking a little bit at trends, and it looks like if you're, even if you're doing age-adjusted rates, certain things look like they're going up in spite of, accounting for that.
And I wonder about maybe, you list the built environment and housing. What about throwing like assisted living facilities and nursing homes and
Yeah, I think we're taking kind of this pathogen approach and trying to just accumulate the numbers, but I think our surveillance system, our outbreak surveillance system really points to those facilities as being, a place that is very vulnerable to outbreaks. Yes?
Do you recommend that people test their own water in their, whatever their premises that they live in?
No, we don't. That question came up a lot in the aftermath of the finding of Naegleria fowleri in the water systems in Louisiana, because these were systems where there were parts of the system that were really dead zones in terms of chlorination. Like there was almost no chlorine there, and people wanted to know, well, should I get a chlorine test kit and test my water? And we said, we basically struggled with that a little bit, but we think no, because we don't really know what you can do about it. We're not going to recommend that you add a booster chlorination to your house. That's a kind of a complicated engineering issue. So I think our message is really more about educating people about appropriate uses for your water. That it's safe for drinking. It's not sterile. You should not use it with medical devices. Yes, not in the nose. Yes.
Do you know what happened with the water in Flint? It's like better to drink now?
I'm not the best source of information on the I'm aware of the issue to some degree, but I'm not completely plugged into that issue. Thanks.
What was the question?
It was a question about the water situation in Flint, where they changed from Lake Huron to a river, right? Okay, yeah. There have been some water quality concerns following that change. Thank you very much.
Thank you again, Dr. Gargano. We're going to break for a break, and we'll reconvene in 30 minutes. See you at 10:30. Please visit the poster and sponsored session. Does it just not change that fast? Okay. All right.
We're doing hand this back sheet for engraving, or okay. Okay.
In the past, I think somebody had taken it to the place where I live in the
Okay.
And then I'll have to arrange to get it back to you.
That's fine.
We'll be on the call. We probably will meet in April.
Okay.
Probably meet with Andy.
Give a solid break.
Yeah.
Take a deep breath. It's always nerve-wracking to be up here and be like,
I have to stop there.
did you get to my poster?
Okay, okay. Okay. Can't get the contagion up again.
It is still recording?